Hey guys, and welcome back to Clinical Physio with me, Phil Richards. In today's video, we're going to be taking you through thoracic spine palpation. And when we're palpating the thoracic spine, this is going to be a bit different than our peripheral joints. We're still going to palpate for pain, tone, deformity and swelling, but because we're palpating spinal segments, we're going to be looking at pain, range and end feel at those specific segments, particularly looking to see if things are hyper or hypomobile. We can also perform rib palpation for pain, range and end feel if it's appropriate in our subjective history. We're going to palpate in our prone and our sitting position initially, and we're going to go through all the key things you need to do. Right, let's get to it. Let's get clinical. So before we start our palpation of the thoracic spine in the prone position, we're going to do it with the patient either sitting or standing so we can see what effects gravity is going to have on the spinal erectors and the tissue, because obviously it's going to be forced to contract to hold our patient upright. We can get an idea of what's working, not working, etc. So that's why we're doing it. And so we're going to have a look at muscles to start with. So the key areas to look at and feel for are the upper trapezius. So we're going to come in and feel here for sort of your swelling, laxity, tone, pain, etc., as we've talked about before. We're going to run all the way down the spinal erectors. And we can also check in on the QLs. And the way we're going to find the common point for irritation to the QL in the upper aspect is to come to roughly the 12th thoracic vertebra, so T12. We're going to come midway across and tuck under the 12th rib and palpate in and around this section. And see if that's tender too. So they're the key muscles we're going to look at. So after that is a good idea to have a general check for scoliosis. So what you can do is just get your fingers and run them down the thoracic vertebra on the spinous processes and just see if things feel even or whether your fingers are sort of drawn away, which might be a mild scoliosis, which could be a structural or a functional thing. After that, we can look at the scapular height and difference. So we can feel for the spine of scapulae on either side and see if that's different. And we can also look at the relative heights of the iliac crests to see if there's any imbalance there. We then need to put all of that into context of sports, hobbies or occupation and see if that's relevant to it, and then we might be able to modify that in order to get the person out of pain. So what I'm going to do for you now is I'm going to have a look and a feel and let you know what I see, as if we were doing this in clinic now. So we know that the spinous scapula is lower here. And I can feel more tension in the upper trapezius to the left. I feel underactivity in the left side and more activity in the right side. So this would make you think that this person was probably right hand dominant. And again, running all the way down with the spinal erectors, more underactive on the left and more overactive on the right. Checking in for our QLs. Similar, no difference there. Feeling for the scoliosis. I can feel some left rotation, so the spinous process is a little bit more to the right. It's quite subtle. And that's pretty good at the lower part, so that's fine too. So we could put that together with our clinical picture and see if it's relevant. Does our patient have right-sided pain? Is it because it's overactive? Do they have left-sided pain because it's underactive? They're just useful ways to get in and feel before we carry on with our further assessment process. So now we're going to go through how to find particular landmarks so you know exactly which part of the thoracic spine you're palpating. The easiest way of finding each segment is by locating the spinous process at each particular level. So how do we do that? Well, there's two ways of finding specific segments as a starting point for your thoracic palpation. We can either start at the top and work down, or we can start at the bottom and work our way up. So if we're going to start at the top, we're thinking about T1. So how do we find T1? Well, the way we're going to do it is we're going to locate C7 first and work down from there. So this will be a little bit similar to how we did some cervical palpation, if you remember. So what we're going to do is we're going to ask our model to extend their neck up, and we're going to feel for where movement doesn't occur at the most superior aspect. The last one at the lowest portion to move is C6. The one that doesn't move down from that is C7. So now we have our C7 spinous process. So we now know that there's only 7 cervical vertebrae. So if we move down from the prominence here of the spinous process, we feel a gap, and we move a little bit further down, we have another bony prominence, which is our spinous process of T1. So that's how we're going to find T1. So what about T12? So we're going to come down this way. And so what we're going to do is we're going to find the lowest ribs. So we can follow the shape of the rib cage here, and we can swoop and follow the line up to where it meets. So now we know we're on T12 due to where the rib of the 12th rib is going to join in with the thoracic vertebra. So one more thing to say is about the scapulae. Whilst this is not always precise, this is a really good rough guide that the spine of the scapula, where it comes across, is roughly in line with T3, and the inferior angle of the scapula is roughly in line with T7. So when we find our particular segment, it's commonplace to perform 2 main spinal palpation techniques. We can either perform a central posterior anterior pressure, also known as a central PA, direct on the spinous process, or a unilateral posterior anterior pressure, also known as a unilateral PA, where we push down on either side of the vertebra. When performing your technique, it's commonplace to put the heel of your hand, commonly known as where the pisiform bone sits, onto the aspect of the vertebra being palpated. So for instance, if we roughly lined up T3 in line with the medial border, I could put my pisiform bone sitting so. And from here, we form a V shape with our 3rd and 4th digits that sit on top of the index finger of your lower hand, and we can palpate from here. As a therapist, we'll be standing at the side of the plinth for our palpation. As more force is required to effectively palpate the thoracic spine vertebra, the therapist is going to need to use their body weight a little bit more than if they were palpating the cervical spine. Therefore, the therapist's elbows should be in an extended position, which allows their hands to remain soft during the palpation so we can feel what's happening to the segment being palpated. So when performing a central PA, your hand should be placed directly on the spinous process which you are palpating. So for instance, if we went to the inferior angles of the scapula and came across, we'd be roughly in line with our T7 spinous process, and my hand will go on like so. And we're going to go directly through the center of the vertebra. I'd like you to bear in mind the steepness of the spinous processes of the thoracic vertebra. They arc very much steeply down relative to the cervical and the lumbar vertebra. So when we're pushing down on that segment, we're not going to be exclusively gliding the joint, which would tend to be angled a bit more up this way. However, what we are going to be able to do is still get an appreciation of the pain range in the end feel, and it's going to be in a repeatable way, so we can objectively look at it and come back to it and perform it another time to see if things are changing. For a unilateral PA, find your spinous process. So again, if we come to T7 roughly to here, and then what we're going to do from here is we're going to move a thumb width laterally. So we're going to be roughly here. And this is going to be where the transverse process of the vertebral body below is located. So for example, We're here at the moment on the T7 across here. So this is actually going to be the T8 transverse process. So in this position, it's really useful to note that we're not actually going to be palpating the transverse process from here. It's too deep for us to be able to feel. There's a lot of muscles lying on top of it. However, it's good to be aware that our hands are overlying on this particular part of the vertebral body. The direction for your unilateral PA is also a directly downward movement, but just occurs on either side of the vertebra. So our hand's going to come across like so, with the pisiform pressure, and we're going to be putting a PA force through like so. So let's talk about rib palpation. So rib palpation is not routine to the examination, but it can/should be performed if the patient is complaining on pain on breathing, or if the thoracic spine pain is radiating outwards, or indeed pain is localized more specific to the lateral aspect of the thoracic spine. It may also be a good idea to perform rib assessment later on if your patient is not responding to thoracic treatment, if the rib assessment was not performed on the initial assessment, to see if a dysfunction is lying there, and hence why it's not responding to your treatment. So how do we feel the ribs posteriorly? I'm going to start with the 12th rib and work our way up. It's a lot easier to access and feel what's going on here than it is further up here. So we're going to put our hands on the lateral aspect of the patient's thorax. We're going to feel with our index fingers to appreciate the ribs and their angles. We're going to work our way down, still feeling for ribs, until we get to a point where the ribs stop. So now we know we're on the 12th rib, and we're going to work our way up, and we can trace the angle up to T12. So to start to feel up and get appreciation for the ribs, what we're going to do is we're going to protract the patient's scapula, so that this isn't occluding the rib palpation, but also we can trace the medial border and trace an imaginary line down, and it's a good, nice, easy way to feel the ribs from here so you can appreciate the angles. So what does that all mean? So if we start with our 12th rib again, we work our way down, we slide up, and we imagine this line down here. So this should be quite an easy access place for you to feel the ribs. So from here, I can now start to trace. And when I want to go to the rib above, I just feel more superiorly, there's going to be a gap, and then I can feel another rib, and I can trace this line all the way up. So as you start to trace the ribs up and feel them, you can start to see if this brings on any soreness subjectively from the patient, which could indicate potentially a fracture or bony bruising. If we wanted to test to see if there's an irritation or a common posterior subluxation of the rib head, which would be in the costovertebral joint, we're simply going to go a further thumb width out from the transverse process and repeat the same PA procedure from here. So what does that mean? So if we go to the spine of scapula, for instance, we know this is roughly T3. If we come a thumb width out, we know we're on the T4 transverse process. If we come further out, we now know we're going to be more local to the costovertebral joint. So we can perform our PA pressure either with thumbs or with our pisiform and our V shape from here. Some clinicians like to perform what's called a rib springing, where they'll find a rib and they'll perform a glide, it's sort of a PA pressure, but sort of guided towards midline. And the thought process being that it's going to affect at the joint from here, from pushing with this hand. So by pushing here, it's going to spring here. The only problem with this is because of the flexibility of the ribs, we have no way of knowing that actually if we do push here, whether it's actually going to meet here or if all the bending pressure is just occurring here. That's why we'd suggest that by coming out 2 thumb widths, we know we're more approximated to the costovertebral joint, and we should perform our palpation to here to see if it brings on our symptoms that our patient is complaining of. An additional technique you can add to your skill set is Boney Percussion. We can percuss down the spinous process and indeed the ribs to see if it elicits exquisite pain and tenderness. We perform this, as you've just seen, by simply tapping with the index finger. It's with a firm pressure but a relaxed hand. So it's the kind of relaxed swing you're going to have when you perform your reflex testing with your knee. So the finger's going to be reasonably firm, but the wrist wants to stay relaxed. It's not a sharp, digging, clawing action, because that's likely to just elicit a pain or an unwanted response anyhow. So when we do this, we're going to work, as we said, down, and we can come, and we've just performed our rib palpation earlier, so we can palpate a course of a rib and tap along there as well. If we find an abnormal difference between our left and right, or indeed our central tapping, and the patient has a history that could indicate a fracture, most commonly from a trauma, or we could have an osteoporotic wedge or rib fracture from coughing or sneezing aggressively, and we need to be aware of that, because those subjective signs along with this percussion technique could indicate that's what they're clinically presenting with, and it may drastically change our management of the patient. Another pathology to bear in mind, albeit a rare one, is a pathological fracture, which arises if a particular vertebral body or rib has been affected by a metastatic cancer. So you need to look out for other related red flags, such as weight loss or systemic unwellness in association with this, and discuss your concerns with a senior as soon as possible, or refer on and out as necessary. So now we're actually going to go through the palpation of thoracic spine as we would do with our patient in clinic. And what I need you to bear in mind is when we're performing our central and unilateral PAs, we are influencing both the bony and soft tissue structures, and to gauge the pain range and end feel at each segment. So let's go through it. So we're going to start at the top this time, but remembering that we could, from previously in the other videos, start from the bottom. So I'm going to ask our model to extend their head up, and I've already got a good idea where I should be because of the prominence of around the C7 segment. So I can feel as he lifts his head up that this bit's not moving, so I know it's the first one that's not moving. I know I'm on C7. I'm going to feel for this spinous process. I'm going to roll down where there's going to be a small gap, and there's going to be another prominence here. Now I know I'm on the spinous process of T1. So from here, I use my pisiform hands to place it on that spinous process, my V grip shape on top, and then I extend my elbows and I lean through with my body to appreciate all through the range, respecting the patient's pain and symptoms. From there, I then move a thumb width out and put my pisiform there and perform exactly the same PA. So now it's a unilateral PA, and this is going to be on the T2 transverse process. I come back from my T1 to come to the other side. So now I'm on the right side, and I perform my PA here. And this is going to be our T2 transverse process glide. So we come back up to our first transverse process, our first spinous process, not to confuse you. And from this T1 spinous process, we feel down, and there's going to be a gap and then another prominence. So this is going to be our T2 spinous process. From here, again, I get my pisiform grip, my V shape on top, my elbow is extended, lean through my PA pressure, and appreciate all through the range, respecting the patient's pain, and see how that feels for our pain range and end feel. And again, I come out a thumb width. So now this one was the T2 spinous process. So I know if I come a thumb width out, I'm on the T3 transverse process area. And I perform, again, pisiform hand, V grip over the top, elbows extended, and push through to appreciate the pain range and end feel there. We work backwards, backwards to the side to come over to the right part, and we're just going to repeat the same procedure, guys, all the way through, all the way down until we get to T12. So as I'm explaining it, it might seem quite cumbersome, but actually when you're in flow of it, this is quite quick and easy. But I wouldn't rush this process to start with until you become quite familiar with it. So essentially all we're doing is we're locating a T1 or a T12. We feel the spinous process, we put our pressure through, we come out a thumb width either side and repeat the procedure for the transverse process, and then we work down a segment. And we just keep repeating that until we've covered the thoracic spine. So lastly, I just wanted to talk about alignment of vertebral bodies generally. So when you're feeling your thoracic spine, spinous processes, obviously we're going to be very diligent in feeling for the prominence, then the gap, then the prominence to find our specific levels for our palpation. But also generally what would be a good idea is to use sort of your all four fingers and roll them either side of the spinous process as you work your way down. And if you feel that the spinous processes are sitting a bit more rotated one side to the other, so for instance in this model I can feel that the spinous processes are sitting a little bit right of the midline, that means that this thoracic spine is in a certain degree of left rotation to draw the spinous processes from here over here. Now it's really common to have these sorts of deviations in people anyway, and it doesn't mean that because they've got rotation it's the source of their pain, but it could do. So if you feel someone is particularly rotated, it might be a good idea, if they have thoracic pain, to ask them about their sports, their hobbies, or their occupation, and see if they're always stuck in a relative left or right rotation. So for instance, with this person, I can feel a left rotation. I would say, do you work in an office? Is your monitor always slightly more to the left? You have two monitors, you're always looking more to the left. Or are you a tennis player? Do you always favour your forehand, and are you excessively rotating to the left? Because in knowing this, we may be able to modify or change their sports or work specific positions to alleviate their symptoms. So when we perform our palpation, we are looking for pain, range, and end feel at each spinal segment. In terms of pain, we want to know at which level we recreate the patient's pain, and whether this is different on either the right side or the left side, or indeed in the central part of the vertebral body. In terms of range, when you're performing your palpation, try and take your mobilization through from the start of the range, through to the mid-range, and to the end of available range. If you are stopped at a certain point, either due to stiffness or pain, make a note of this. In terms of end feel, you're looking to see if a particular level is hypermobile, hypomobile, or normal. If it is hypomobile, this may tell you that a lack of movement occurs at that particular segment, and the resulting stiffness may be causing your patient's pain. It is also very important in the context of a neurological examination to see whether or not you recreate a patient's neurogenic symptoms such as paresthesia or shooting pain in and around the trunk when you palpate on a certain point, as this can illustrate to you the spinal level at fault for their symptoms. So, for example, if we perform a right unilateral PA at T6, which reproduces a numbing sensation around the right side of the trunk, we know that the T6 segment is likely to be sensitized and may be the source of the patient's symptoms. Remember the purpose of what you are doing. If the patient is in a very irritable or hypersensitized state, you may be reducing their trust in you if you go into the palpation at each level too aggressively, which may stir their pain up. In fact, if you find that this is the case, you may wish to only perform light palpation or omit the palpation altogether at this point and save it for another time. If your patient is in a hypersensitized state, where you find that even very gentle palpation is unnaturally sore, this can tell you enough as it is. So let's summarize this video on palpation of the thoracic spine. Start your palpation when your patient is in either a sitting or standing position so that you can assess soft tissue structures whilst they are active, the alignment of the spine in case of a scoliosis, and the relative levels of the scapulae and iliac crests. Of course, there's always more you can add in, but this is a great place to start. Then move on to palpation with your patient lying prone. Make sure you're aware of how to find your palpation points, whether you were to start palpating from the upper thoracic spine down to the lower thoracic spine, or if you were to start palpating from the lower thoracic spine to the upper thoracic spine. With your patient in prone, you're going to palpate each thoracic spine vertebra with a central PA and a right and left unilateral PA. You may also choose to palpate the ribs. You are assessing pain, range and end feel at each thoracic spine level. And that concludes our video on thoracic spine palpation. From here, we suggest you look at our other videos in the clinical physio catalogue, such as thoracic observation and thoracic resisted testing. That's all from us. We'll see you again soon.